Good morning, friends. We'll begin today's session on anatomy. Today, we're going to look at the sella, the paracellular region, and I think we are also going to cover very briefly the pineal region. I hope you can hear me well. We can begin now. Okay, so what are we going to look at today? We'll look at the various bits of the anatomy of the sella itself, the bony anatomy. We'll look at the pituitary gland, and then we will cover the supracellular region, especially the chiasm, the floor of the third ventricle, which we have looked at briefly last time. Then we'll move on to the paracellular region, where we'll look at the carotid arteries within the cavernous sinuses and the cranial nerves within the cavernous sinuses. I think some of this will go in further detail next week when we are looking at the morphology and the anatomy of the nerves themselves. Okay, so what's the area we are going to concentrate on today is going to be here, right here at the skull base, right at the base of the brain, at this junction of the anterior and the middle cranial fossa. And it's a very small area, and not only is it small, there are also very many important structures which are kind of cramped in that area within the uh, sella and the paracellular region. Uh, so why sella turcica? Okay, so sella turcica, when I looked up, it was described as a Turkish saddle, not a European saddle, but a Turkish saddle, and it was different from the later which came about the European saddle in that it has this high backrest as well as this anterior pommel. Apart from the sloping sides, and this is just a picture which I've grabbed from the net, but it's not too dissimilar to this pituitary fossa here that we see with the floor where would the rider would sit on it, and the backrest which is formed by the dorsum sella. And then we will look at the anterior pommel which is formed by the tuberculum and the clinoid processes in a minute. And of course, this sella turcica itself is housed within the body of the sphenoid bone, which can be pneumatized to different extent, making it difficult for us to appreciate the anatomy between CT and MR scan. But let's have a go now. Okay. Again, very important to mention that when you're looking at a skull base, really you have to make sure you look at the CT as well as an MR scan. The CT very useful to look at the definitions of the bone itself, especially the cortical definitions, as you can see in these two pictures. Whilst an MR scan, extremely important to look at marrow. Whilst you can see here the marrow within the odontoid process on this T1 sequence, you can see the bright fat marrow. But in this patient where there is abnormality involving the dorsum sella itself over here going down the back of the clivus with the soft tissue, but also the abnormal marrow. Remember, the marrow within the fat has to be bright on T1 sequence, whilst here it is infiltrated in the patient who's got metastases from cancer of the breast. So CT and MR very complementary. I think that's a very important message to be highlighted. Okay, so let's look at detail at this anatomy of the sella turcica. So as we said, it's like a shallow groove which sits within the sphenoid sinus, which can be very variably pneumatized, as you can see here. And it is separated from the sphenoid sinus by a very thin bone over here called as a lamina dura. And this bone was used in the past as a landmark on X-rays to see whether there is any raised intracranial pressure. And any erosion of this bone on a lateral skull X-ray was thought to be a significant finding, demarcating raised intracranial pressure. Of course, now we have moved on since then. Uh, the pituitary gland sits within the fossa, and we said this has a backrest, which is a dorsum sellae on the posterior aspect, which slopes down into the clivus, leading towards the anterior lip of the foramen magnum. Then we have got the floor of the sella turcica, which is formed by the lamina dura, which separates it from the adjacent sphenoid body and the sphenoid sinus. And anteriorly, and here this is the area we are looking at. This is the anterior most bit, the dorsum sellae, which we saw on the sagittal. That's the dorsum sellae. The structure in front of the dorsum here is the sella itself, the cavity, and more anteriorly here in the midline is the tuberculum sellae. But as we go more laterally, we reach into these extensions of the sphenoid sinus, if you like, which separated from the anterior skull base, and that's the lesser wing of sphenoid, and more laterally into the middle cranial fossa. This piece of bone here, a large wing of bone, is actually the greater wing of sphenoid. But the structure we are interested in is this small piece of bone here, which is on either side of the tuberculum, which we don't see in the mid-sagittal plane, of course, because it's in the parasagittal plane, are these medial extensions of the lesser wing of sphenoid. This is the lesser wing of sphenoid, the medial extensions, and these are the anterior clinoid processes, which of course we see here on a CT scan. So we have got the tuberculum cilia in the midline here, which is the structure which is here, which separates the anterior skull base in the midline from the sella. So this is the anterior skull base here in the midline, and then the sella would be somewhere here. So that's the tuberculum, and on either side of the tuberculum are the anterior clinoid processes. I've selected this image specifically to show that the anterior clinoid processes are part of the sphenoid sinus, and because they are parts of the sinus, they can be pneumatized. And here you can see the pneumatization on the left side, whilst this is a non-pneumatized anterior clinoid process. And it's very important to recognize that for a radiologist, for a neurosurgeon, especially because this can pose problems, because you can see here when the bone itself covering that anterior clinoid process here, it's very well corticated here, but whilst here it is slightly dehiscent, and any diseases within the clinoid process can then spill over and cause problems within the structure here lying medial. And here you can see the optic nerve, which starts from the globe here, going posteriorly into the intracranial compartment, and this portion is actually the optic canal. So the optic canal, it lies medial to the anterior clinoid process. Here, this is the anterior clinoid process. The optic canal is going to be somewhere around here, and I've shown you here the soft tissue windows here to highlight the optic nerve, which traverses the back compartment of the orbit behind the globe, reaches into the orbital apex, and then via the optic canal extends into the intracranial compartment. So that's one area to look at. The other area which is very, very relevant, especially when we talk about the paracellular region, is this foramen here, which lies lateral to the anterior clinoid process here, and it's a lateral over here. And that foramen is a superior orbital fissure. So this canal here transmits the optic nerve and also the ophthalmic artery, and we'll come back to that later. But this foramen here, which is much larger, transmits the third, fourth, and the sixth cranial nerves through it as they reach the extraocular muscles within the orbit. This is just to show you in the coronal format here, the anterior clinoid process, the anterior clinoid process, which are these processes here, and lying medial to them, which are these structures here, are the optic canals. And here you can see the clinoid process with the well corticated margin, and just lateral to that and beneath that actually are the superior orbital fissures, which will lead into the orbit with the contained third, fourth, and sixth nerves. And some of this anatomy will keep on reappraising during this course of this session. The reason to identify this tuberculum cilia and the clinoid processes, because they can harbor tumors. There can be a site of tumor, and the ubiquitous tumor, of course, is the meningioma. And this is just a pictorial representation to show how this meningioma, based on the tuberculum, you can see the epicenter. The epicenter of the tumor is at the level of the midline of the sella, the tuberculum cilia over here, and it is not only centered here, it is bulging posteriorly, and you can see that's the pituitary gland, which is displaced posteriorly. So this is a tuberculum cilia meningioma. It is not a adenoma of the pituitary gland, and you can see the plane of demarcation, and it is starting to encroach upon the optic chiasm and the infundibulum of the pituitary gland, as opposed to this tumor over here. So here again, the tuberculum cilia meningioma is in the midline, whilst the more lateral clinoid process, again, to look at the anatomy, this is the lesser wing of the sphenoid leading towards the anterior clinoid process, and this is a tumor which is based in the around the anterior clinoid process. Again, here the anatomy. So if you look at this over here, this is the lesser wing of sphenoid leading towards the anterior clinoid process, and this is a tumor which is surrounding the anterior clinoid. So this is a paraclinoid meningioma, as opposed to this in the coronal section here, the midline tuberculum cilia meningioma. This one more lateral is the paraclinoid meningioma based on the anterior clonid process over here. And the relevance, of course, is that this tumor is more likely to encroach into the optic canal. So the anatomy was the same as before. This is the anterior clonid process. This is the orbit with the optic nerve leading into the uh, suprasellar region. So the optic nerve is going to be here. This is the optic nerve here. This is a carotid artery with the flow void, the black flow void. Again, very important to identify these structures. And you can see how the carotid artery is encased by the tumor, but the tumor is also encroaching upon the optic nerve. So for surgeons amongst us here, important to realize that any approach towards the paraclinoid or the supraclinoid carotid artery involves drilling of this anterior clonid process, making it a much more difficult task, especially for aneurysms around this area. Uh, when we talk of the sphenoid sinus because it is pneumatization within the sphenoid bone, it's very important to identify, and this is for any radiologist amongst us, the degree of pneumatization, and also for the endoscopic surgeons, it's very important to understand the degree of pneumatization of the sphenoid sinus. And I've shown you there are various classifications, and basically we have to see how much of the sphenoid sinus is pneumatized in relation to the sella turcica over here. Whilst here you can see that the pneumatization is only in the anterior bit, here you can see it has extended a little bit more, but still stops in front of the sella, whilst here it has then extended into the region of the sella itself. And the reason why it's important is because imagine a tumor within the suprasellar region, a pituitary adenoma, for example, and if a surgeon is approaching it via the sphenoidal route, transsphenoidal endoscopic route, it is much easier to drill this sinus as opposed to this sinus to reach a tumor which is in that location over here. So for the radiologist, especially amongst us, it's important to try and mention that in the report if you're commenting on even a CT angiogram of this area, which is done as a brain lab, or a CT scan of this area to highlight the bony anatomy. And this pneumatization doesn't just affect the sphenoid sinus, it affects the various recesses. We talked about the anterior clonid process. You can see how the anterior clonid processes are pneumatized, but the pneumatization can extend more laterally into the skull base as well. So here, these are the pterygoid processes, and you can see there is now pneumatization of these pterygoid processes at the bases, but also laterally along the lateral wings of the sphenoid sinus. And why is it so relevant? Again, because the disease can spread along here. You can get inflammatory sinonucleus disease, which can spread here, and you can understand why these patients can then develop facial pain, because some of these cranial nerves which supply the facial sensations are going to traverse these areas here, and this is the foramen rotundum. But more about this next week when we look at the cranial nerves themselves. Okay, so now this bone and the sinus, what do they house? It houses the pituitary gland, which is really the important, perhaps one of the most important endocrine glands located within the cella itself, within the cavity. Uh, and we're going to look at in a bit more detail about the anatomy now of this pituitary gland. So we have moved on from the bony structures which house the gland to the gland itself. Okay, we know very well that the gland has an anterior lobe and a posterior lobe, and it's got an infundibulum over here, and it's again here to show the pituitary gland on the sagittal T1 sequence. This is the sphenoid sinus. The black is of course the air within the sinus. You've got some fat in the lower end of the clivus over here. This is the dorsum sellae here. The floor of the sinus, we don't see the bone separately because we have got air, and then this is the tuberculum, and again we don't see the bone because it is a very well pneumatized sinus. And this is the pituitary gland, and you can see the anterior pituitary, and you can see the bright T1 signal of the posterior pituitary, and it hangs itself from the floor of the third ventricle by this infundibulum of the pituitary gland. Uh, and again, in a slightly more detail, so the anterior lobe of the pituitary gland, if you can concentrate on this diagram over here, is also called as the adenohypophysis as compared to the posterior lobe, which is the neurohypophysis. So the anterior lobe of the pituitary gland, it is composed of three portions. The pars tubularis, of course, we don't see it separately on an MR scan. We don't see the pars tubularis, but it's important to understand that it exists in this portion surrounding the infundibulum. So you can get adenomas even in the suprasellar region, which can surround the infundibulum. Then you have got the bulk of the anterior pituitary, which is the pars distalis, which lies within the gland itself, and a very small compressed tissue which is a pars intermedia. And again, it is difficult to resolve this on MR, but it is the part of the anterior pituitary which abates the bright T1 signal of the posterior pituitary. So the pars intermedia is going to be in this location. But very important to identify the bright T1 signal of the posterior pituitary over here on the sagittal T1 weighted sequences. This is a T2 weighted sequence just to show you the anatomy here. Uh, this is the third ventricle. We have looked at it last week and we'll talk about it a bit more later. But this is just to show you this is the infundibulum which hangs the pituitary gland within the sella turcica over here. This is a very high resolution T2 sequence showing the recesses of the third ventricle. So this is the third ventricle. This is the pituitary infundibulum. In front of that is the optic chiasm there. And this is the optic chiasm over here. And this is the optic chiasm on the diagram over here. So you've got the suprachiasmatic recess of the third ventricle CSF filled, and then this is the infundibular recess of the third ventricle because it extends into the infundibulum of the pituitary gland. So this is a bit of anatomy of the pituitary gland in the slightly higher resolution T1 and T2 weighted sequences. Let's look at the embryology so we can understand why do we talk about the adenohypophysis, why did we talk about the neurohypophysis as separate entities. And this is where we have to go back to this early embryonic phase. This is around about the fourth week, and just to set the stage over here, the notochord, you will remember we talked about the notochord which influences the formation of the neural tube, which is this structure over here, and the neural tube at the cranial end will form the vesicles, the prosencephalon, the diencephalon, the mesencephalon, and the rhombencephalon. And we are going to concentrate at this diencephalonic structure over here. And this is where the ectoderm, just concentrate on this image over here. This is where the ectoderm of the mouth is in contact with the neural ectoderm, which comes from the diencephalon. And again, if you concentrate on this picture over here, you can see the pink outlined ectoderm of the oral cavity in contact with the neuroectoderm of the diencephalon. Uh, and again, to highlight an important feature here is that there is no mesoderm. The mesoderm is more lateral and then surrounds the developing pituitary gland later on. But at this stage, the ectoderm of the neural origin and the ectoderm of the oral cavity are in contact to each other. And the anterior pituitary and the posterior pituitary are yet to develop, but it's the posterior pituitary which starts developing first, which sends a signal to the adjacent what we call as a stomatodium. So you got an invagination of a fold from the third ventricle inferiorly, third ventricle which is part of the diencephalon, diencephalon cavity. It starts as outgrowth and that becomes the infundibular recess and later on forms the posterior pituitary over here. But it stimulates, it sends out local hormones and stimulates the growth of this structure, which is the Rathke's pouch, which starts to elongate and touch and gets in contact with the pituitary uh, 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 from the posterior pituitary from the diencephalon, and that's the extension of the stomatodium, and eventually it will lose contact with the stomatodium, and that's what is the Rathke's pouch, which is now in contact with the posterior pituitary, and this now forms the anterior pituitary. And here you can see the anterior pituitary, all of it in its glory. Anterior pituitary, this is the pars anterior or the distalis, and this small bit is the pars intermedia, which eventually is in close contact with the posterior pituitary, and the small space of the pouch itself can be sometimes seen as a thin cleft within the pituitary, or sometimes it can give rise to cysts. And this is just to again highlight that the anterior pituitary also surrounds the pituitary stalk at its base. So this is a bit of the embryology of the gland. Very important to realize that the mesoderm itself has not come in contact till at a later stage when it starts to surround this developing pituitary. And why am I mentioning that is because the mesoderm is the structure from which the bone and the cartilage will arise. So the chondrification process starts much later on after the formation of the pituitary gland. And here you have then subsequently the pneumatization of this ossified chondroid tissue, which develops later in postnatal life. So it's important to realize the uh, diencephalic origin of the posterior pituitary and the stomatodium origin of the Rathke's pouch and the anterior pituitary, because that is what. So this is a postnatal CT scan now, mid sagittal, anterior, posterior. So this is the clivus over here, and these are the developing centers of ossification. So this is what we call as a basis sphenoid. This is the basi occiput. This is actually a synchondrosis where they have yet to fuse. But here a structure within the base of the sella turcica over here, this small channel is a remnant of that Rathke's pouch, which started around about here to reach the pituitary infundibulum, to reach the posterior pituitary. And this is persistence of that channel called as a persistent craniopharyngeal canal. And sometimes you can see it on, especially in young children, as a small channel which leads into the roof of the nasopharynx over here. But sometimes they can be big, especially if they are large in size, and they can remain so, and the pituitary gland can actually descend within that persistent craniopharyngeal canal. And just to show that again over here, so this is the roof of the nasopharynx, this is the ectoderm, the stomatodium, the developing mouth, the nasopharynx, from which we have got this Rathke's pouch, and this is a diencephalon with the inferior recess, the posterior pituitary. And here you can again see that encephalocele in this patient, because this canal itself has not obliterated, and hence this is the junction over here of the oral ectoderm and the diencephalonic neuroectoderm. And this is a herniation of meninges of the pituitary gland through this encephalocele, through this persistent channel called as the craniopharyngeal canal. So just to remember the embryonic, the neuroembryology of this region. And again, just to finish off this embryology business, Rathke-Scaleff cysts, or these cysts within the pars intermedia, these are remnants of the cysts, and because they are lined by cuboidal columnar epithelium, they can contain various secretions within them, and sometimes they can be fairly bright on T1 sequences, as this case, or they can be very fluidy, as in this situation. Okay, so that was a bit of embryology. So let's come back to our normal anatomy. And when we do a normal pituitary scan, we do a sagittal T1, we do a coronal T1 and a coronal T2. And this is just a selection of slices of the coronal T1 sequence. So here we have a mid-coronal T1 sequence over here of the pituitary area, the temporal lobes on either side. You got the frontal horns over here, the optic chiasm, the pituitary infundibulum, and the pituitary gland. So that's the anatomy that we need to identify. And as you move forward here from the optic chiasm, you can see the optic nerves, which are going to lead towards the orbit and the optic nerves through the canal over here. You'll remember the anatomy. These are the lesser wing of sphenoids and the anterior clonid processes, with the optic nerves lying just medial to them. And as you go more posterior behind the optic nerves, we extend into these structures, which are the optic tracts, which go further laterally and into the lateral recesses, and then they are going to relay into the lateral geniculate bodies, which are going to be within the posterolateral thalamus. So these are the optic tracts as you go by. Again, some more structures of relevance over here on this sequence. Here you can see the carotid artery here in the suprasellar region here. So it's at the level above the clonid process. So the clonid process is here, and we are just above the clonid process. So this is a supraclinoid internal carotid artery, the M1 segment of the middle cerebral artery, and the A1 segment of the anterior cerebral artery. And note here how the anterior cerebral artery is actually arching above the optic chiasm over here. That's normal anatomy. The A1 segment is always above the optic chiasm. It becomes a variation when it becomes infraoptic. The other bit of anatomy to highlight in this area is as you go more posteriorly over here, you can see actually the third ventricular recess coming into the coming into the base of the infundibulum. So this is the infundibular recess, but on either side of this infundibular recess, and remember we are much more anterior here, we are in front of the thalamus, in front on either side of this infundibular recess are these very thin areas of gray matter over here, and this is the hypothalamus. And we'll look at this in a bit more detail later on. That was the T1 coronal. This is the sagittal T1. And again, important to identify this sagittal midline T1. And it's easy to identify if you have got the infundibulum in the midline, if you've got the bright T1 signal of the posterior pituitary, if you've got the anterior pituitary, which tends to be iso-intense to the adjacent brain parenchyma. You have identified the pituitary infundibulum. In front of that lies the optic chiasm. And as you move more laterally, you can see the optic chiasm leads into the optic nerves, which are here. And same story on the other side here, the optic nerves on either side going into the optic canal just over here. Excuse me. And that was a midline image. And just to show you again in the midline, just above the optic chiasm are these two anterior cerebral arteries over here, and you can just about see the anterior cerebral artery. So the A1 segments and the ACOM complex is actually in the midline just above the optic chiasm. And behind the sella lies the basilar artery here, much further away in that prepontine system we talked about last week. Uh, uh, we have been talking about the pituitary adenohypophysis and the neurohypophysis, and again just an important point to remember. So we said that the posterior pituitary, which is here, is actually a downgrowth of the a diencephalon, and it's basically the neurons which lie, and we talked about the hypothalamus over here, which lie along the inferior recess, the infundibular recess of the third ventricle over here, and these have their axonal projections. So this posterior pituitary is nothing but a continuation. The neurons are continuation of the cell bodies which lie within the inferolateral walls of this third ventricle, i.e. the hypothalamus, which has these fiber tracts, axons, which terminate into the posterior pituitary. And the same holds true if you look at the blood supply of the pituitary gland. So here this is kind of reverse. This is posterior pituitary is on the left hand side of the screen, the anterior pituitary is on the right hand side, and you can see the neurons here in the hypothalamus which will send down the axons, and the peptides will be released. The oxytocin ADH will be released directly into the venous circulation, whilst over here the anterior pituitary is separate from the nerve cell bodies which are which are situated in the anterior aspect of the hypothalamus. And here you can see the portal venous system, as we call, of the hypophyseal artery, which acts like a conduit between the neurons which are there in the anterior aspect of the third ventricle and the pituitary gland. So the signals from the hypothalamus can directly influence the posterior pituitary, but the signal from the anterior aspect of this third ventricle is not going to directly influence. It is going to influence by releasing hormones into these hypophyseal artery branches, into which themselves will then act upon this anterior pituitary gland. So that's an important difference to note. Uh, again, continuing with the anatomy in the coronal plane, this is again the anatomy is not different. So if you have got the optic chiasm in the midline, if we identify this bow type appearance, and then the infundibulum which is in the midline, the pituitary gland here which sits above the sphenoid sinus, and we have looked at this Anatomy of the paracellular region, the pre-chiasmatic optic nerves here just in front, the optic nerves which are leading into the optic canal, which lies just medial to the anterior clonard process, which are here, the anterior clonard process. And the anterior clonard process is just a prolongation of the lesser wing of sphenoid as it comes towards the sphenoid body itself. So the anterior clonard process and the pre-chiasmatic optic nerves as they extend into the optic canals over there. And again, to show the important anatomy of the clinoid anterior carotid artery, we'll talk about the anatomy of the carotid artery a bit later. But just to show you, this is the cavernous portion of the carotid artery in its distal part. It's going to swing back over here. This is where it swings back and then circles backwards medial to the clinoid process. So this is the paraclinoid anterior internal carotid artery lying just beneath the optic chiasm over there, and there it is, the internal carotid artery. And we have talked about the A1 and M1 segments earlier on. So here it is, the carotid artery on the left hand side, the MCA and the ACA, and the ACOM is going to be somewhere here, and the right ACA just about there, lying above the optic chiasm. And this anatomy is very important when we are evaluating the tumors arising from the pituitary gland, because as they start to push upwards, as they start to push laterally, we have to try and identify what is the relationship of these tumors to the supraclinoid internal carotid artery, to the A1 segments and the optic chiasm. Uh, and again, just to finish off over here, the anatomy of the pituitary gland, this is what is normal. We have talked about the anterior posterior pituitary, and look at the depth of the pituitary fossa over here. But sometimes you can get agenesis of the anterior pituitary with a very small pituitary fossa, and you can just about see the posterior pituitary hanging through the pituitary infundibulum over here. This is the chiasm in the front, and these are the mammillary bodies at the back. And this is the patient with agenesis of the adenohypophysis, so there is hardly any sella which has developed at all. And what has happened to the posterior pituitary? It is ectopic. It is still along the floor of the third ventricle. It has not descended itself into the pituitary fossa. And you can say that it's posterior pituitary because you have got the bright T1 signal of the posterior pituitary there. And sometimes you can get ectopic posterior pituitary as an isolated finding with a normal appearing anterior pituitary. So you can have various developmental anomalies of the pituitary gland. Again, I cannot highlight why we have to carry on looking for that posterior bright T1 signal, because its absence on a thin section high resolution T1 sequences can mean various pathologies, and these are all the various things that can give rise to absence of that bright T1 signal, leading to diabetes insipidus, and you can realize trauma being the most commonest cause. So in the patient who has DI following trauma, if you can look at the bright T1 signal of the posterior pituitary, its absence would suggest interruption, usually an interruption to the infundibulum, and hence Wallerian degeneration of those hypothalamic axons, which normally would terminate into the posterior pituitary. Some variations, it's important to recognize in the neonate, the pituitary gland is usually bulky, especially in the anterior pituitary, because they have got a large number of prolactin cells, and also the gland itself tends to be more brighter in general on T1 sequence, not just the posterior, but also the anterior pituitary tends to be much more brighter on T1 sequences. And it is thought to be because of increased high protein content within them, and also because of the high endoplasmic reticulum, according to microscopic studies. And this bulky pituitary and the signal within the anterior pituitary usually normalizes within the first 2 years of life, when it will assume the more adult configuration. The other important variation to highlight is a slightly bulky appearance, where it becomes more convex superiorly like here, and it can in fact abut the optic chiasm as I've shown over here. And this typically occurs in women, in young ladies around puberty, in the pregnancy, and in that early postpartum period, when the pituitary gland becomes hyperplastic and can actually start bulging superiorly. Okay, so we have talked about the bones, we have talked about the sinus, we are now jumping up into the suprasellar region. We have talked about the pituitary infundibulum, which is that slender conical shaped structure which suspends the pituitary gland from the hypothalamus itself. And it's usually nice and thin and slender, as you can see here, and it is fairly in the midline. But sometimes it can be get thickened, as in this patient over here. And if you're suspecting pituitary infundibular disease, it's very important to give contrast, as is in this patient over here who's got hypophysitis of the pituitary gland and inflammatory disorder. But of course, it can be involved in many other causes. Including tumors and or inflammatory diseases like sarcoidosis and Langerhans disease. Just above the pituitary is the third ventricle, and we have talked about the third ventricle in detail last week. And just to highlight some of the important structures here of the third ventricle. So this is just a pictorial representation over here. The third ventricle lies beneath the fornix and beneath the internal cerebral veins, which are about here. On either side of the third ventricle, we can just about see the glimpse of the thalamus. The third ventricle has got a roof, which we have looked at previously. The third ventricle has got an anterior wall, which extends from the anterior commissure, which is about here, to the optic chiasm. Anterior commissure here to the optic chiasm, and that is nothing but a structure called as lamina terminalis. And we talked about this during neuroembryology. So the third ventricle is nothing but the cranial end of the neural tube. We have got the aqueduct, the fourth ventricle, and similarly you'll have the spinal canal, which is a neural tube which comes here, and the anterior end of that neural tube, the anterior neural pore, is the lamina terminalis. So that's the anterior aspect of the third ventricle and the structures along the floor of the third ventricle. We have talked about this earlier on. We've got the optic chiasm, we've got the infundibulum over here with the pituitary gland at its lower end. Just along the posterior aspect of the infundibulum, which merges along with the rest of the floor, this structure over here is called as a tuber cinereum. And behind the tuber cinereum, this bump over here are the mammillary bodies. And these all are structures which belong to the hypothalamus. And this is just to show you in red the recesses of the third ventricle over here, the posterior recess, which we'll talk a bit later, the pineal recess of the third ventricle, which is shown over here. So the lamina terminalis and the anterior suprachiasmatic or the optic recess and the infundibular recess, along with the tuber cinereum and the mammillary body. Why I'm spending so much time on the third ventricle itself, just to clarify the group of structures which are poorly described in radiology literature called as a circumventricular organs. And these are kind of conglomerate organs which are sort of along the margins of the ventricles. And which are these organs? These are all of these organs. And one of the most important is the neurohypophysis, including the median eminence, including the tuber cinereum. And it also involves these other structures, the lamina terminalis, the fornix of the hippocampus, the pineal gland. So these are all circumventricular organs. And why am I describing this? Is because there are very important organs which, though they reside within the brain parenchyma, are slightly different. And the way they are different is that they lack the normal blood-brain barrier. So here I'm showing a normal blood-brain barrier in the scapulary over here, this single endothelial cell nucleus, and you can see how these cells join up each other with very tight junctions, and this constitutes the blood-brain barrier. What we have not shown here is, of course, the food processes of the astrocytes, but that along with the surrounding endothelium itself constitutes a tight blood-brain barrier. Whilst in the circumventricular organs, this blood-brain barrier is much more leaky and it is fenestrated, as you can see, these small holes. And what this allows is structures within the blood lumen, the peptides, we can cross over easily and reach these circumventricular organs. And these large molecules then will be assessed by these circumventricular organs, and it will decide what is the osmolality of the blood, what is the pH of the blood, what are the electronic constituents of the blood. Uh, and then it will regulate changes. And how does it regulate changes? It regulates changes through the hypothalamus itself, which we said is part of the circumventricular organs. And this is just a sort of a diagrammatic representation of this hypothalamus over here. This is a coronal section here, a third ventricular recess, and a third ventricular recess over here. And this area over here, I've shown it's slightly disproportionate which is around about here. This is the median eminence, and the reason to show you this is that there are special cells within this. These are called as tanycytes, which have got cilia, and they line this third ventricle, and because of the permeable blood brain barrier and these tanycytes, they will pick up signals with changes within the blood constituents and regulate homeostasis. And the way they do that is by sending impulses to the posterior pituitary if there is a change in the osmolality. If you're thirsty, the antidiuretic hormone is going to be channeled. Similarly, in the fright and flight episodes, you'll get noradrenaline and adrenaline, which will be released by the hypothalamus itself. Similarly, you'll get surges within steroids by stimulation of the anterior pituitary. And it's ACTH hormone. So this is to show us the importance of hypothalamus as a regulator of various body homeostatic functions over here. And this it does by this various group of nuclei which line this very small area over here. That is where all these nuclei are located, and they influence the pituitary gland, and by its influence on the pituitary gland is going to influence the rest of the body itself. And again, just to show you the anatomy over here, this is the pituitary infundibulum. The posterior aspect of the pituitary infundibulum is a tuber cinereum, and this is the mammillary body. Over here again, the anatomy, this is the mammillary body just in front of the midbrain over here. This is the midbrain. Just in front of the midbrain is the mammillary body, and this structure here is not a mammillary body. This is a small nodule along the posterior aspect of the pituitary infundibulum. This is a hamartoma. And if you have got any neurologist amongst us, you can see this patient who's confabulating and has got acute psychosis. And if you realize what this patient has got Wernicke's encephalopathy with cortical psychosis, which affects this specific part of the hypothalamus along the floor involving the mammillary bodies. And I've talked about the importance of the homeostatic functions of these circumventricular organs. Again, this is the hypothalamus over here. Similarly, we have got this area over here within the medulla along the floor of the fourth ventricle called as the area postrema. This patient was having constant hiccups and vomiting, and this is because this is an area which controls the emetic center, and if it is disease, it is going to be excessively stimulated, like in this example patient over here. This is an inflammatory condition which affects the floor of the third ventricle, the floor of the fourth ventricle, and here you can see the hypothalamic recess, the infundibular recess with the hypothalamus on either side, which is being affected over here, and also the periaqueductal region. So this patient actually has neuromyelitis optica as because of involvement of the circumventricular organs, but you can see the hypothalamic involvement over there. Okay, so let's move further on. We are now in the suprasellar region. To talk about a diaphragma sella. It is nothing but a fold of membrane that kind of separates the pituitary fossa itself from the basal cisterns, and it's a fold of the arachnoid over here which separates it. But sometimes it can be deficient, and when it is deficient, the CSF which is there in that suprasellar cistern is going to start herniating into the sella itself, and it is going to flatten the pituitary gland because of the constant pulsations. And this is what we are seeing here, where the pituitary gland is actually flattened against the pituitary fossa, giving rise to this kind of a empty sella or a partially empty sella appearance in this situation. And this can also happen as a result of raised intracranial pressure. And just again to show you the presence of this diaphragm is in this patient with a pituitary adenoma, which starts within the pituitary gland, but because the diaphragma sella is here, it's centrally deficient, it bulges superiorly, but it gives rise to this kind of a snowman, or a, if you believe it's a figure of 8 appearance, because the diaphragma is pinching this tumor on either side at this level, and this is where the diaphragma sella is. And here you can see the chiasmatic compression. Okay, so we are now into the suprasellar region. We'll talk about the optic nerve and the chiasm. The optic nerve itself starts from the back of the globe, and we have talked about this previously many times. It is nothing but a continuation of the lateral geniculate body neurons which traverse via the optic chiasm into the back of the globe towards the retina over here, and that's why they contain a bit of CSF surrounding them, which is shown in this patient over here. So that's the optic nerve itself within the orbit, and it's going to enter into the cranial compartment via this optic canal. Optic canal, we have looked at the Clannad process and the optic canal which lies medial to it and containing the optic nerves. What we have not shown is the ophthalmic artery, which also arises and traverses this location normally. And then the optic nerves in the pre-chiasmatic, this is the chiasm, this is the pre-chiasmatic segment, leads towards the chiasm, and then more posteriorly on either side of the hypothalamus, we are going to extend towards the lateral geniculate bodies are these optic tracts. So this is the anatomy of the optic apparatus, or what we call as the anterior visual pathway, which we can see on imaging. Beyond this, we don't see it separately as the anterior visual pathway. Just to show you this example again here over here, these are the orbits, these are the optic, these are the anterior clonid processes, a bit of the brain coming here, the gyrus rectus over here, and you can see the optic nerves and the carotid artery here very intimately related over here. And you can see this is a carotid termination, the middle cerebral artery over there, this is the carotid termination. But what you can see over here, the optic nerve over here being compressed by this small aneurysm arising from the paraclinoid segment of the internal carotid artery. And again, for the surgeons to remember, when you're approaching this aneurysm, the drilling process that is involved, which can lead directly onto this aneurysm, hence making it a more difficult proposition. Again, the anatomy, again, showing on this CT scan and the MR scan, the anatomy is still the same. The Clannad process is over here, the Clannad process is here. These are the optic canals. We have looked at the superior orbital fissure, more inferolaterally over here, the optic nerves which are residing within the optic canals, and just to show the degree of pneumatization, which is asymmetric in this case, which leads into the optic canal, into the anterior clonid process in this situation. Uh, so this is again just to show you the coronal T2 sequence showing the optic chiasm, the carotid artery with the anterior cerebral artery just above. When we are looking at the pituitary gland, of course, it's important we look at the rest as well, but especially for midline structures, pituitary is a midline structure. It's important to look at the other midline structure. The other midline structure here is optic chiasm, and in this patient over here, say sagittal T1, coronal T2, you can see that the optic chiasm is thin, especially on the right side. And the other structure to note is the midline septum pellucidum, which separates the two lateral ventricles, the frontal horns. And here you can see the absence of septum pellucidum. Not only that, you can see that the pituitary gland is small in size in this patient. So this patient has got a condition called as septo-optic dysplasia, which involves the optic chiasm, which involves the pituitary gland, and which involves the septum pellucidum, the septo-optic dysplasia in a patient who has pituitary hormone deficiency, typically the growth hormone deficiency. And these are just to show you examples. This is not a pathology lecture talk, but just to show you examples of the tumors which can affect the optic chiasm. Here, a coronal flare sequence. This is patient with neurofibromatosis, which is typically associated with this tumor optic pathway gliomas. Here you can see the bulky appearance of the prechiasmatic right optic nerve over here. Just over here, the right prechiasmatic optic nerve as compared to the left side. And this is another patient where you can see the mammillary body right at the back. You don't really see the pituitary infundibulum, but you've got a very bulky appearance of the optic chiasm in the patient with NF1. And again, a various host of different tumors which can compress the optic chiasm, and you can see this tumor over here which is involving the sella but has also extended into the posterior fossa, reaching up, compressing the chiasm. A different patient over here. Here you can see the tumor starting within the sella itself. This is a meningioma, whilst this is an adenoma of the pituitary gland with a degree of necrosis and blood within it. And you can see how the optic nerve itself is stretched and compressed. You can see the optic nerve which is stretched and compressed by this adenoma over here. Another concept to mention in terms of the optic chiasm is to describe its relationship to the sphenoid sinus itself. Whilst here you can see the optic chiasm is much more anterior. In this patient here, the optic chiasm is much more posterior. And this concept is important to describe where the optic chiasm is in relation to the pituitary. Normally, in 50% of the patient, it's going to be lying just above the diaphragma sella, situated right centrally over the pituitary gland itself. So this is a normal. But sometimes the optic chiasm may be stretched anteriorly, where it lies over the tuberculum, and this is called as a prefixed optic chiasm. And sometimes it can be lying posteriorly, right at the back, and this is called as a postwick. And these two are roughly about 25% each. Whereas here we get 50% of the times the chiasm lies above the pituitary itself. And again, the importance being, whilst approaching the tumors via the endoscopic route, it's important to figure out where the optic chiasm is. And finally, the last bit of the optic apparatus are the optic tracts. As I have said before, they lead towards the lateral geniculate body or here. And of course they can be involved in diseases behind the dorsum sella, but sometimes even big pituitary tumors or even optic chiasmatic tumors can cause signal changes within the optic tracts, and that can be due to edema. And this is just to show you the similar show you that example of what happens over here in the coronal plane. This is a coronal plane over here, the third ventricle, the lateral ventricles, and these are the optic tracts which are leading towards the lateral geniculate body, and they have got a bit of CSF surrounding them. But if you have got tumors in that location, they can compress and can trap this CSF space, giving rise to edema surrounding that optic nerve, which is what we are seeing here, edema surrounding the optic nerve, which is what we are seeing here as well. From the supracellular, now we're going to move towards the paracellular region, which contains the which basically is the cavernous sinus with the contained carotid artery and the nerves themselves. And we're going to try and see each of one of them in turn. So let's start with the cavernous carotid artery. Okay, so this is the carotid artery coming from the neck. This is the lateral view. This is the AP view. So if you look on the leg on this diagram, you got the cervical portion, then climbs to the petrous, and then on either side of the sella, the cavernous portion, which is what we will be seeing today, and then swings up and back. So this is the anterior genu, as we call, where the ophthalmic artery arises. And then this becomes the supraclinoid. The clinoid processes are located at that level, and then we get the supraclinoid process with the posterior communicating artery and the choroidal artery, and then the carotid termination. We'll talk in detail of the carotid circulation when we do the arterial anatomy. And this is the AP representation. The sella is somewhere here, and you can see how the carotid artery is in close approximation to the sella over here. And this is with the bone in situ. You can see the sella over here, and this is the cavernous carotid artery. And this is the supraclinoid artery, the ophthalmic artery going in the front. When we look at the carotid artery in the paracellular region lying within the cavernous sinus, extremely important to look to make sure that we have got the flow void present. And here this patient who has had repeated strokes in the past within the right hemisphere, the normal flow void within the left carotid, and you can see the absence of the flow void on the right side over here, and on this post contrast sequences suggesting occlusion of that right internal carotid artery in its cavernous portion. Not only can be occluded, sometimes it can be aneurysmal. And here you have got a coronal and an axial CT angiogram. This is that same carotid artery we were looking at earlier on. Different patient, of course, with normal enhancement on either side of the sella. But here there is aneurysmal dilatation encroaching upon the pituitary gland. So if you imagine this patient has got a pituitary adenoma over here, and a surgeon is approaching it through the endoscopic route, it's going to be a dangerous proposition. And hence the importance to identify the position of these carotid arteries, identify the position of the anterior communicating artery, of the anterior cerebral artery, when the patient has got a sellar mass lesion which is large enough and it can encroach upon these arteries, or there can be incidental aneurysms like in this patient. And just to show again the vulnerability of this artery, here you've got a carotid artery with the eccentric tumor extending towards the right side. This is the left cavernous sinus with the carotid artery. The tumor is encasing here, pushing it laterally, and a surgeon operating in this area debulking the tumor has to be wary of this encroachment of the tumor towards cavernous sinus and involving the carotid artery. And similarly over here you can see how the carotid artery is displaced laterally as compared to this side. So the normal anatomy is distorted. And this is another patient with a fairly extensive sphenoid meningioma of the skull base encasing the carotid artery here in the proximal aspect just before it enters the cavernous sinus over there and narrowing it. The cavernous sinus itself, it's a venous plexus. And it's a very important venous plexus right at the base of the brain over here on either side of the sella turcica. And it's a plexus and it's got communications with various veins and various sinuses itself. Amongst its drainage channels, one of the most important ones is the orbit, and it drains the superior and the inferior aspect of the orbit via the ophthalmic veins, which traverse the superior orbital fissure, which we talked about earlier on, and lead itself into the cavernous sinus. So these are the superior and inferior ophthalmic veins from the orbit, which lead into the cavernous sinus on its anterior aspect via the through the superior orbital fissure. But the cavernous sinuses also communicate across the midlines in front of the sella, over here in front of the sella or behind the sella, or in fact beneath the sella as well, beneath the pituitary gland. So they can communicate across each other. The other structures that are drained are the superficial middle cerebral veins, which are the cortical veins draining the lateral aspect of the frontal lobe and the temporal lobe anteriorly, and these veins will drain into the cavernous sinuses, and the cavernous sinuses drain posteriorly via the superior and inferior petrosal sinuses, which are located along the petrous apex over here, and they lead towards the sigmoid sinus and the jugular vein. Another important plexus right at the back of the sphenoid, along the back of the clivus, is the clivoluminous plexus, and again forming a very important communication. And you can see how these sinuses are very, very intercommunicated with each other. And this is just a pictorial representation of what we talked. The sella right in the middle with the cavernous sinuses on either side, with their communications anteriorly with the orbit, laterally with the frontal lobe and temporal lobe veins, and posteriorly with the pterygoid, with the petrosal sinuses, and posteriorly with the basilar plexus as well, or the retroclavial plexus. And we can see some of the structures on the on angiography or venography rather. And here you have got the cavernous carotid artery, and you can see the enhancement within the cavernous sinus over here, the retroclavial plexus over here, a bit of the superficial middle cerebral vein, which is going to drain into the cavernous sinus here anteriorly. More posteriorly, you can see the petrosal sinuses, which are draining along the posterior aspect of the cavernous sinus towards the sigmoid sinus. This is the superior petrosal sinus along the superior aspect of the petrous bone, and this is the inferior along the inferior aspect of the petrous bone. So this is the cavernous sinus anatomy on the venogram. And it's important again, of course, to identify this anatomy because it has a role in understanding the pathology. So this patient has had trauma, and following trauma, you can see that they have developed engorgement of the superior ophthalmic vein. So this is a CT angiogram picture over here. These are two different patients. And you can see early opacification of the superior ophthalmic vein. For the radiologist amongst us, it's important to look at this. Even on a plain CT scan, if you are following up patients who have had trauma, pay a close attention to the superior ophthalmic vein on a plain scan. If it looks bulky in a patient who's had got significant injury of the skull base, this could be related to a carotico-cavernous fistula, like in this patient over here, where the fracture has resulted in direct communication of the carotid artery with the cavernous sinus, and hence blood, which normally drains back along the ophthalmic vein into the cavernous sinus, cannot do that. And because of the high pressure within the cavernous sinus, blood is now actually flowing anteriorly, resulting in high pressure within the orbit, resulting in proptosis, resulting in ecchymosis and the pulsatility and all the other symptoms. And of course, for the interventionalists, this is an important a bit of information, because they can use any of these venous routes to approach the sinus. This is a patient with an indirect fistula, the lateral carotid angiogram. Over here, you can see the from the back of the cavernous portion of this internal carotid artery. This is the dorsal clival branch, which supplies a conglomerate vessel, which is a fistula, which then drains anteriorly via the superior ophthalmic vein, causing proptosis within here. And here you can see a small wire has been placed via the superior ophthalmic vein, and approach selected to embolize the cavernous sinus to treat this fistula at the back end of the cavernous sinus. And of course, the cavernous sinus can get occluded as well. You can develop thrombosis within the sinus. It's of course a venous structure, and the commonest cause, of course, is infection in the head neck area, around the orbit, or within the sinuses, which can cause this filling defects within the cavernous sinus, and also bulging of the lateral wall of the sinus. A very life-threatening complication if this were to happen. The cavernous sinus, of course, contains nerves within it, and we have got the third, fourth, the sixth nerve, and the first and the second division of the trigeminal nerve. The third division, the mandibular division, doesn't really enter the cavernous sinus. It exits much before it enters the cavernous sinus, and we'll talk about this next time. So that's the cavernous sinus over here, with the nerves lying along the lateral wall, except the sixth nerve, which is lying within the sinus itself, close to the carotid artery. And this is just to show you the high resolution post contrast MR scan over here, the pituitary infundibulum, the gland, the carotid artery in the supraclinoid portion, in the cavernous portion over here, and the non-enhancing roots of the third, the V1 and the V2 nerves. The fourth nerve is a very, very small nerve that we do not see on normal imaging. And of course, it's important to identify these nerves, because these nerves can be involved in various neoplastic and non-neoplastic conditions. And whilst here this patient has got a tumor over here, again to show the anatomy, this is a high resolution T2, the trigeminal nerve over here coming from the ventral surface of the pons, entering the Meckel's cave, and you can see the small rootlets of the trigeminal nerve, and the mandibular nerve is going to descend down from here. Whilst in the same patient over here, you can see that there is a tumor here occupying the Meckel's cave, also extending into the cavernous sinus anteriorly, and this patient has got a trigeminal schwannoma. And not only does it involve the Meckel's cave, but it is also extending along the mandibular division of that nerve. So this is the Meckel's cave in the same patient with the rootlets. This is a rootlets, and here this structure over here is the mandibular nerve going descending down into the masticator space over here via the foramen ovale. And here you can see the tumor also extends into the mandibular nerve via the foramen ovale. I think it's 10 o'clock. I've got another 10 minutes to share if you have got time, or we can stop here. I'm happy to stop.
Please continue.
Okay, thank you. I knew you would give that answer, so okay, we'll carry on. Also very important to realize when we talk about the perineural disease, remember cavernous sinus contains the third, fourth, and sixth nerve, and these nerves are basically supplying a lot of the head face area, and any malignancies in that region are going to track along the nerves and present themselves into the cavernous sinus itself. And we'll talk about the perineural disease in detail next week, but this is again just to show you a large sphenocavernous meningioma over here, which extends into the middle cranial fossa. But not only that, it is starting to extend via the superior orbital fissure into the orbit over there, and here you can see it's coming into the orbit. So again, the anatomy is the same. This is the lesser wing of sphenoid terminating coming into the anterior colonoid process, and this is a superior orbital fissure. The optic canal is going to be here, so it's starting to encroach into the orbit over here. And this is another patient with the same tumor. This is the foramen ovale with the contained mandibular nerve which goes inferiorly, and here you can see the tumor encroaching into the foramen ovale and the mandibular nerve on the right hand side. So this is perineural disease, but we'll talk about that in detail next time. Okay, so that was about the cellar. We have talked about the sella, the bone, the pituitary gland. We have looked at the supracellular region, including the hypothalamus, and then we have talked about the paracellular region, including the cavernous sinuses, the carotid artery, and the cranial nerves within them. So let's just finish off the next 10 minutes talking about this pineal region. uh, Mentioning pineal region separately because it doesn't really come into any specific category, but it was useful to talk about this because we were talking about the third ventricle, the posterior recesses, and the circumventricular organ of which pineal gland is part of. So the pineal gland here, which is shown by the arrow, is very a small structure, and really in adult human life, it is probably related important because of its regulation with the melatonin secretion and sleep cycle. But it's also important because it's related very vital structures over here. And here you can see the back end of the corpus callosum with the splenium. Just underneath the splenium over here in the roof of the third ventricle. Remember, we are here in the third ventricle in the midline. So this is the roof of the third ventricle. We've got the internal cerebral vein in the midline. Just lateral to the internal cerebral vein, not shown over here, are the columns of fornix, but we'll see that in a minute. And the pituitary, the pineal gland itself is suspended along this roof of the third ventricle by this commissure called as a habenular commissure, and inferiorly by the posterior commissure. So this is how the pineal gland sits in just beneath the splenium of the corpus callosum, and by the posterior commissure it attaches itself to the tectal plate or the superior aspect of the midbrain. And the small recess of the third ventricle which extends into the base of this pineal gland is a pineal recess. So that is the anatomy of this region. So let's look at that. So this is the corpus callosum, splenium of the corpus callosum. Just underneath that splenium is the internal cerebral vein, which join up together to form the vein of Galen. So over here you're going to get the vein of Galen, and then the straight sinus which leads towards the torcula over there. This is the tectal plate over here. So over here is the posterior commissure, part of the posterior commissure, which is going to suspend the pineal gland. Again, the anatomy, just to revise the sagittal anatomy, T1 sequences. This is the third ventricle, which we have seen ad nauseum today, with its recesses anteriorly, with the floor of the third ventricle mammillary body, that the midbrain over here, the thalamus on either side. And the structure that we didn't see on the midline section was this structure, the columns of fornix, which are also within the roof of the third ventricle, just underneath the body of the corpus callosum, along with these dark lines, which are the internal cerebral veins. And these internal cerebral veins leads towards the vein of Galen. Again, here the pineal gland with the posterior commissure attaching itself to the tectal plate. The anatomy in the coronal plane. This is the pineal gland. The pineal gland, the internal cerebral veins over here, just above them. The columns of fornix seen better on the coronal, and you can see how they are just a little bit lateral to the internal cerebral veins, and hence in the midline section you don't see them. And just above them lies the corpus callosum and the splenium of it. And you can see how the pineal gland is so closely attached to the tectal plate over here, and hence any tumors of the pineal gland or any tumors in this area are going to compress the tectal plate and are going to compress this CSF structure, which is the aqueduct of Sylvius, which communicates the third ventricle with the fourth ventricle, causing obstructive hydrocephalus. So this is the region that we will just look at now. One of the biggest problems which we see in imaging is this cyst of the pineal region, and it's a very common. We'll see it in at least 50, if not more, percent of cases in adults. And they can come in variable sizes ranging from a few millimeters, can range up to 15 to 16 millimeters, and they can be very variable. Usually they are very thin walled, but sometimes you can see enhancement following contrast administration. If you do a flare sequence, they may not necessarily suppress completely, so this content may not be necessarily cystic, and that can be a source of misjudgment sometimes, but also leads to frequent follow-ups in these situations. But the anatomy to show again here, this is a posterior commissure here by which the pineal gland attaches itself to the tectal plate, and just the rim of the cyst, which also forms the habenular commissure here in the front, by which it is attaching itself to the splenium of the corpus callosum. But just again to highlight the importance of looking at the pineal region in relation to the tectal plate, in relation to the aqueduct, but also in relation to the cerebellum itself, the superior aspect. So just some examples of pathology here. Uh, and here you can see it is actually not along the superior aspect of the pineal of the pituitary of the tectal plate. It is actually along the inferior aspect of the tectal plate. So you can immediately say that this is not likely to be from the pineal region. It is in fact below the pineal region, and on axial T1 and on sagittal T1 it has a bright T1 signal. And if I were to give you the rest of the sequences, it's suppressed on fat, and this is a quadrigeminal plate lipoma. But of course you can get tumors in this location as well, and it can be difficult on the axial sequence to say exactly where the tumor arises, and it's so important to look at the sagittal sequence. And here, just to show you the normal again, the splenium of the corpus callosum, the internal cerebral vein, and then the pineal gland. And here you can see the internal cerebral vein along with the splenium of the corpus callosum, and the tumor which lies underneath it, underneath the corpus callosum over here, is the tectal plate tumor, which is also extending itself into the aqueduct. While this another patient over here, you can see the internal cerebral vein is actually displaced inferiorly as opposed to this patient over here. And this patient actually has got a very well defined tumor which is outside the tectal plate but compressing it. And this is a tectal plate meningioma or a falcotentorial meningioma, which is at the edge of the falx, bit at that level of the tentorial hiatus. Internal cerebral veins, we have looked at this on MR. So this is the corpus callosum over here, the splenium, the anatomy is still the same. The internal cerebral vein, this is a CT venogram picture, join up together just underneath the splenium to form up the vein of Galen, and then the straight sinus which leads towards the torcula. A small filling defect which is just a pacunian granulation. This is the tectal plate over here. So the pineal gland is going to be located just around here. So this is just to show you the normal anatomy of the internal cerebral veins, and very important to identify that in tumors around this area to describe which way they are displaced, but also to remember that they can be abnormally involved in tumors around this area, and also because of thrombosis. Just another variation in the theme here, you see it sometimes in children. This is what is called as a falcine sinus, which is a midline sinus, which actually drains part of the inferior sagittal sinus or the internal cerebral veins into the superior sagittal sinus, instead of into the straight sinus. This is just a variation in anatomy, but you see this predisposition sometimes in children. Uh, Again, to show you the abnormality over here, this is the previous case with the normal anatomy of the internal cerebral vein, the vein of Galen, and the straight sinus. And here you can see the very thready appearance of the superior sagittal sinus with a lot of longitudinal filling defects. The vein of Galen doesn't enhance at all with a filling defect within it. So this patient has got thrombosis within the deep venous system, also thrombosis affecting the superior sagittal sinus. Uh, uh, So this is another patient over here. Again, venous system anomaly with a hyperdense rounded structure here in the midline, causing obstruction over here. And here you can see this is a vein of Galen aneurysm, which is seen in neonates or pediatric cases, which is basically a malformation within the choroid along the lateral walls of the thalamus, which gets enlarged and can impede this venous outflow, but also impede the CSF drainage pathways in this cases. And this is an angiogram just to demonstrate the fistulous communication via the choroidal branches of the posterior cerebral artery into this big venous pouch, which then subsequently drains via the straight sinus. Um, and just to finish off, really, just for the to say that this region over here, it's not necessarily just always involved with tumors. Sometimes you can get non-tumorous conditions as well, which can affect here. This patient who's severely alcoholic has got this degeneration within the corpus callosum, but also has developed degeneration with enhancement, acute degeneration within the splenium of the corpus callosum, a condition in the right clinical setting you would call that as Macchiafava-Bignami syndrome. I think I've already overstepped by 12 minutes, so I will stop there, and I'll field any questions if you have. So that was a conclusion of sort of brief tour through the sella, suprasella, paracellar region, and the splenial region. We'll discuss these topics on cranial nerves next week, I think, but we'll confirm that with Tanvir. Okay. Is there anything you wish to ask me? Any questions? No questions? Shall we stop there? Okay, so thank you, friends. Thank you for listening. I'll tell you, it is such a pleasure to prepare for these sessions because I'm learning things as we prepare. Okay, so next week we'll look at the cranial nerves 1 to 6. Enjoy the rest of your Sunday. Bye bye.
Thank you.